Hi, everyone. Thanks so much for attending today. I'm Maureen Baldwin. I'm an OBGYN and I have a practice focus designation in pediatric and adolescent gynecology. And my practice is concentrated in menstrual management, mainly hormonal menstrual management. So that's my component of our shared clinic. And I'll turn it over to Dr. Haley to tell about her part and about how our clinic works.
Great, thanks, Maureen. So my name is Christina Haley. I'm a pediatric hematologist here at Oregon Health and Science University, and I focus my clinical work on non-malignant hematology. And we're excited today to talk about our clinic and our kind of how our clinic's set up, and then just some cases or how we approach some of the work that we do. We're excited that you all joined us. It might be that some of you have joined us for a presentation previously, and so some of this might feel like information that we've reviewed before, but it feels like in this space where we're all working to improve access to care and the care for women and girls with blood disorders, that it's good to hear all the information a few times and to try to hear it kind of maybe with a different perspective each time. So these are just some pictures of some of the patients we care for to remind us that life happens outside of clinic, and eventually someday post-pandemic, we'll get back to doing all these fun things. So today we'll talk about our combined hematology gynecology clinic here at OHSU. We'll review what's normal and what's abnormal for periods, and talk about signs and symptoms that are important to report to the medical team regarding periods, and review some options, and then also highlight the effect of some of heavy periods, which can be iron deficiency, and how to treat it. So we have a couple different interdisciplinary hematology gynecology clinics here at OHSU. We have the clinic that Dr. Baldwin and I co-direct, the Spots, Dots, and Clots Clinic, which is for patients ages 9 to 21 who have both bleeding and clotting disorders. And then there's a combined adult hematology and gynecology clinic for the patients who are over 21. And then there's a kind of ever evolving obstetrics and hematology clinic for patients who are either pregnant or prior to becoming pregnant who need some hematology obstetrics combined care. So we'll talk about our clinic, which is our dedicated clinic offering hematology and gynecology care for adolescents with uteruses who have bleeding or clotting disorders, or who are being worked up for bleeding or clotting disorders. The patients are seen by both me in hematology and Dr. Baldwin for gynecology. And then our follow-up might be either with both of us or just with one of us, depending upon the care that is needed. And patients have access to all the services through our hemophilia treatment center, as well as the Center for Women's Health, where our clinic is housed when we're in person. So we see patients in our clinic who have known bleeding disorders, who are about to start their first period. I like to call this our welcome to womanhood visit. So we meet the patient and talk to them about kind of what to expect, and to make plans in case their bleeding is heavy, and just to like connect with them to make sure that they know that we're there to help manage if their period becomes challenging or interfering with their life. We also see patients with a known bleeding disorder who are having heavy menstrual bleeding. We see patients who are seeking evaluation for heavy menstrual bleeding who do not have a diagnosed bleeding disorder. And then we also see patients with a personal or family history of venous thromboembolism or thrombophilia or predisposition to clotting. Currently, our clinics are 3 times a month. We see patients on the first and third Thursday mornings virtually. That has been a pandemic gift, I guess. So that in Oregon, our patients are spread out all over the state. And so it's been a good way for patients to access our clinic. And then we still have an in-person clinic once a month as well. And then we add on clinics as needed based on our wait list, or if we can get one in during a school break, so we can minimize school absences if possible. So this is how our clinic is set up. Normally what happens for a new patient who doesn't have a bleeding disorder, they're evaluated by their primary care physician. They are identified to have heavy periods or iron deficiency, and the they're referred either to our hematology team or our gynecology team. And it's kind of noted across our university that if you have an adolescent with heavy periods or iron deficiency, they should be seen in our clinic. So for hematology, we route them to our Spots, Clots, and Clots Clinic, and similarly in gynecology, and then they're seen in our clinic. If it's somebody who's already seen at the HTC, then we'll just route them to the Spots, Clots, and Clots Clinic. So this is how we have it set up. Patient one arrives, they fill out some intake forms, and they're seen by Dr. Baldwin. I usually in pre-pandemic times am coming from our grand rounds meeting. So I'm running across campus, getting back to clinic. And then the second patient is arriving as this is happening, and they fill out their intake form. So getting ready for the next visit. And then Dr. Baldwin and I sit down, and she tells me about the first patient she sees and tells me what her plan might be and what she's thinking. As Dr. Baldwin and I have worked together for the last several years, we now know each other's practice patterns a little bit better. And so she might say, this patient definitely has a platelet disorder. So, they kind of get this, I'm like, oh yeah, that sounds good. Or she'll say, I think this patient would really benefit from tranexamic acid or something like that. And then we talk about what we've read about the second patient, or if it's a follow-up, we might review what we had done the last time. And then I'll go in and see the first patient, and then Dr. Baldwin will start with the second patient. And we then meet again and rediscuss everything. And then I go see the second patient. First patient goes off to see their labs, and the third patient gets roomed, and Dr. Baldwin starts with them. And then at the end of our clinic, we discuss all of our follow-up plans to make sure that we know what we're going to do for each patient, discuss any outstanding issues from prior clinics, and then discuss our upcoming clinic, review our schedules, and make sure we're all on the same page and ready to go. This is how our clinic functions, but there are lots of different clinics across the country that might have different setups depending upon what they have available to them. So for example, you might have a different grouping of patients, or they might be seen in a different location. So in this case, maybe they're seen at the hemophilia center, and it's real focused on the hemophilia connections. And the medical assistant might be more gynecology focused to bring in some of those expertise. Another example might be that instead of a gynecologist, it might be an adolescent medicine doctor. And then maybe the nursing support is more hematology focused. And maybe they have a restriction of they only see new patients. And if somebody has a diagnosis, they're seen in the HTC. Or maybe it's that you have a nurse practitioner and a gynecologist working together, and they're located off campus at a satellite clinic, and they say, we don't see thrombosis in these clinics, so we don't have the expertise, or something like that. And so there's just lots of different setups for this, all focused though on bringing the hematology and gynecology foci together. So I'm going to turn it over to Dr. Baldwin to talk about some cases.
All right, so we've just kind of compiled a couple of example potential cases so you can get a flavor of the types of patients that we might see and how we might do their workup. So in this initial case, maybe we have an 11-year-old with known type 1 von Willebrand's disease, and we had maybe done a preparatory visit, and she had her first period, sends us a message. She has had 4 months after menarche. So at this point, we want to assess how things are going. Her first period was normal, but it was a little bit long, 7 days. And then the next one lasted for 10 days. And she is now referred to really see us for anemia and fatigue at this point. So what is normal? A lot of times we don't necessarily have someone knowing that they have a bleeding disorder, and pediatricians are wondering, well, when should we refer for problem? Menarche being the first ever period is often isolated, and then there's a lull after that, but not always. It does closely follow the growth spurt, usually about 6 months later. So first breast bud development and a growth spurt. When you're buying new jeans for your 11-year-old every 2 months, you should think about getting ready the materials you'll need for pads and stuff. So mean onset is 11.5, and a lot of people think 11 sounds, normal, but then they think a 10-year-old or a 9-year-old sounds really young. So meaning that it's in the middle. So a lot of patients are 9 and 10. If the patient hasn't had a period by about age 16, an evaluation is usually warranted, depending on whether they have other medical complexities. Cycle irregularity is really normal for 1 to 2 years. And frankly, I think even depending on the age of menarche, maybe even up to 3 to 4 years if it starts very young. Average cycle length in a normal period is 4 to 5 days long. And then we have all these intervals of norms that are really based on ovulatory cycles, adult ovulatory cycles. And we have a little bit better data in the last couple of years, kind of doing a systematic review telling us what's normal for teens, and initially in the first 1 or 2 years after menarche, what's normal. So an adult mean cycle interval would be 21 to 45 days. And it's normal even if one cycle is 30 days and the other cycle is 35 days, but a lot of times that gets assessed as irregular. Duration of menses should be less than a week, or that raises a red flag. And generally about 3 to 6 menstrual products per day would be a baseline, pretty normal, maybe a little bit more on a heavy day. In the first 2 years, cycle length can be up to 60 days and still be normal. Less than half of cycles are usually ovulatory, meaning that they almost always qualify for a definition of an abnormal cycle if we were to look. And so it's not uncommon for us to get referrals just for intermittent, heavy, irregular periods and to kind of just watch and wait if it's been in the first 2 years. But what we're really looking for is, do they really have heavy bleeding? And that's the biggest red flag. So if a patient just perceives their bleeding as heavy, that's a good sign, but they don't always have something to compare it to. And especially if their family has bleeding disorder also and may have never been evaluated, the norm in the family might be completely off. We've seen it where families with like 3 sisters and the mom who's had, heavy bleeding with every birth, they just buy these large Costco sized pads and don't think anything of it. But the research definition is more than 80 milliliters per episode. And then this pictorial assessment is what we use in clinical assessment and in research to really get a handle, especially for people who might change their pad or tampon when it's not heavily soaked, maybe every time they use the restroom. And then some of those might add up over time. So you can see on the right here that a heavily soaked pad is going to get 20 points. So if you even just have a few heavily soaked pads during your cycle and maybe 1 per day, even if for a 10 or 7 day cycle, that's easily over 100 points. So when they're talking about frequent clots or frequently heavily soaked, we don't always have to go and count up every single product because we can tell right away it's heavy. So if we go back to this case, we kind of dig deeper into what her bleeding is like during those 10 days, and it ranges from light to heavy. That's pretty common. But also we go into other bleeding symptoms, and there are other bleeding symptoms: nosebleeds, bruising. She's pale, but has no murmur and is normotensive. She does have some bruising, and she's actually severely iron deficient and anemic as well, which is very common for us to see on a first evaluation. So we repeat iron studies, consider reevaluation of bleeding disorder diagnosis, because some patients come to us with a von Willebrand diagnosis and it isn't correct, or it's the wrong diagnosis sometimes. And then we work on menstrual suppression, iron repletion, and making sure that she has school accommodations, because one of our top goals of our clinic is to keep girls in school. Second case, 14-year-old female. Menarche was a couple of years ago, infrequent periods for about a year, but now they're getting to be more regular and are heavier. And it's impacting her ability to go to school, and she's referred with anemia and fatigue, and ultimately is diagnosed with a platelet secretion defect after our testing. If we look closely at her initial evaluation, she has periods 7 to 8 days long that are heavy, with frequent clots and overflow, gushing, overnight, soaking into the sheets is a question I usually ask because that's not something that they can control. Also having epistaxis and bruising, family history of heavy bleeding. And on exam, she's pale, of course, and has bruising. We also do evaluation for hypermobility using something called a Beighton score. And you can look it up on Google and do it on yourself. You might be one of the 3% of people who is like a yoga instructor and is very bendy, but having hypermobility is a risk factor for heavy bleeding. And we also evaluate all our patients for that. And she's also severely iron deficient, as well as anemic. So we've got the diagnosis, no additional testing is needed. And then we work on the same plan for menstrual suppression, iron repletion, and school accommodation. So that's generally how our assessments go. Sometimes testing comes in 2 waves where we do an initial phase with things we think are more targeted toward how severe the bleeding is. And then sometimes a second wave where are repeating previous tests. So, so now that we've found the bleeding, we go through this process of trying to decrease the bleeding, treat the deficiency, and follow up to see if maintenance is reached. So sometimes people wonder, why do we need to treat menses? Isn't it normal to have periods, and are we changing the body and making it abnormal by treating it? And we talk about the goals of decreasing the loss of blood so that we can keep up with demand. So treating, particularly in the case of iron deficiency and needing iron repletion, treating for ability to achieve goals like school. And then also because heavy bleeding is also associated with pain for many people, and that's one of the biggest reasons for missing school. So treating dysmenorrhea by managing menses as well. And then occasionally we're also treating for completely different reasons. Even with heavy bleeding, it might just be because with developmental difficulties, there might be behavioral responses to having bleeding or hygiene difficulties. And so that's a common reason as well. The goals for patients might be different than the goals for providers, and we try to take a patient-centered approach. They may prefer to have just less bleeding overall, or maybe they're willing to accept a moderate amount of bleeding, but they just want fewer days of bleeding. And then adolescents often will request predictable bleeding just to avoid accidents, no matter how small they are. And so sometimes the goals that we have for adults, where we might achieve almost no bleeding, but frequent unexpected bleeding, are not the same goals that an adolescent might have. Providers we want to thin and stabilize the endometrium to keep it from being proliferative, which is where bleeding and excess flooding come from. We want to assess for any contraindications to components of the hormones, such as estrogen contraindications, and consider whether there's a need for contraception in an age and developmental friendly manner. And then we want to decide if we want to trade off a moderate scheduled bleeding versus breakthrough bleeding or no bleeding. And that's what leads us to choose different medications. The options for menstrual suppression are kind of in two categories. And on the left is options that generally provide predictable bleeding with a moderate decrease of about 60%. And those are generally combined hormonal methods of estrogen and progesterone, and they're available in multiple formats for delivery, as well as non-hormonal antifibrinolytic tranexamic acid, which Dr. Haley is going to review. The other side of it is significantly less bleeding, but generally uncertain timing. And those are usually progestin-only methods, and they come in multiple forms. Some of them have variable side effects or insurance coverage or ability for dosing in different manners. And they include both oral forms, injectable forms, as well as implantable forms, such as the arm implant or the IUD, which are both long-acting contraception as well. So I think when people are having their period and they come to you and they're like, I'm having heavy bleeding, it sort of like seems like this emergency of flooding, this sprinkler that you need to like turn off. And it depends on how much bleeding it is. Sometimes we don't need to really turn it off all the way. Sometimes we just need to get it under control. And that's why it's so important to have the shared decision making. So my goal is generally to keep the endometrium kind of in this stage where the arrow is here. So if this is the menstrual cycle and on the bottom, the endometrium is thick leading up to the menstrual phase, and then it degrades and then it rebuilds. And at the beginning of the rebuilding phase, it's kind of got this nice structure that avoids having vascular breakdown and is under control by the suppression of having low estrogen and progesterone right before that timing. And then as more estrogen grows throughout the next phase of the cycle, which is in green there, on the top panel, the endometrium proliferates and thickens. And so more estrogen is not necessarily going to be better. It's usually going to make the lining thicker. On the left side, where the blue line of the progesterone, that down arrow with the P, is decreasing, that drop in progesterone is the signal for the menstrual phase. And so if we can keep progesterone in a stable level, then we avoid having the onset of the signaling for the menstrual phase. So if we look at what the menstrual normal cycle looks like, this is kind of like my cartoon of the estrogens and progestogens. We've got that blue drop of the progestogen just right before the menstrual phase, and estrogens increasing at the end of the cycle. That is coming from the growing follicle, which will then ovulate and create the other hormones that lead to the cycle continuing. And in teens, this cycle is not so great. It's just not quite with it. I'm usually telling my patients, like, you're just not getting it quite together yet. It's still learning how to do it. So if we provide both estrogen and progestin, we're able to suppress the cycle by having a negative feedback to have consistent levels. And then if we use it in a cyclic fashion, such as most of the combined hormone packaged as birth control, then we have this week off, or 4 to 7 days off, where we decrease the dose, and that you get that decrease in the blue line of the progesterone, and that leads to a withdrawal bleed. So we can provide timing of when the withdrawal bleed might happen, or we can give the medications consistently and continuously, and we still might have a little bit of breakthrough bleeding that happens occasionally, but it could potentially suppress bleeding the entire time. And then we might just have a medication where we don't have suppression of the ovary follicle formation, but we might just have suppression of that growth of the uterine lining. And that's typically achieved with many progesterone medications, such as the progesterone IUD, where you might still have cycling and feel symptoms of cycling, but not have the bleeding occur. And so IUD is very successful for treating heavy menstrual bleeding for that reason. We use it in adolescents. We typically provide sedation options. This is a medication, not a device, and it's placed very safely into the uterine cavity, which in teens, especially with heavy bleeding, is large enough to accommodate it. The medication in the bottom right panel is in that capsule right on the frame that allows it to stay in place. So that's a very successful medication, but it is not something that all teens are ready to proceed with. It has, if you look on the bottom panel here, by cycle 3 to cycle 6, 83 to 95% decrease in bleeding compared to a progesterone medication, which had up to 13% decrease in bleeding. So we cite 95% decrease by 6 months. When we use these different hormones on the left column in a combination, we get predictability and regularity, but and decreased bleeding. It has other benefits like acne and cycle symptom suppression, but it does have some risk of stroke and clot, and especially in people with a higher chance of that, such as a family history of genetic predisposition toward clotting. And progestin only has less predictable bleeding, significant decrease, unpredictable outcome, and but safe in nearly all people. There's a lot of concerns out there about hormones, and if you look at TikTok, for example, you'll see lots of things spreading around even these days. Certainly worries about whether it will cause weight gain or fertility problems, and the fact that it's unnatural and we're changing the body, that it might cause mood problems, or it might harm the body and harm development. There's also a sense that once you start this, you'll never be the same again, and that there's maybe no going back. People worry about being sensitized to using hormones. Many of these are myths. So in particular, having any change to fertility is a myth. Having any adverse impact on development is a myth. Having adverse impact on bone growth, and also about weight gain. But it is real that some patients have side effects from hormone medication, and in particular, breakthrough bleeding and change in bleeding pattern is a huge side effect, as well as skin changes for many, some for the better and some for the worse, mood changes in both directions, and weight change in both directions, as well as ovarian cysts in some patients that can cause difficulty, especially in patients with bleeding disorder, if the cyst were to rupture and bleed. So a lot of things to consider in our treatment and management. So follow-up is really important. So we usually really want to ask, like, what is the desired effect, and is contraception also desired? What does the patient want? What can the patient do or tolerate? Can they actually even take a pill, or do they have difficulty swallowing pills or remembering to take a medication? How urgent is this? And then give it a little time to work. And while we're waiting for the maximum effect, we will treat iron deficiency and help with school attendance and follow-up plans. So our approach is generally that we give the patient some sense of, we really think you need to have treatment, or you don't really need treatment, but if you want it, we can offer it. Or we really think you could benefit, and here are the reasons why we think that you would have a better quality of life if you treated your periods. But we really put it in their hands most of the time. And then find out what's important to them about treatment and the most effective methods that are safe. We give them kind of a list of what the options are, and then talk about pluses and minuses and let the team make the decision. So now we're going to go into how do we manage and treat iron deficiency, and then make a follow-up plan. So I will stop sharing and turn my screen over to Christina.
Great. Okay, I'm going to just pull up my screen here. Okay, I just wanted to, before we go into iron deficiency, just talk a little bit about hemostatic treatment. I think this comes up a lot, and we honestly don't have a ton of data, but this is from the CDC, from the Female UDC project a few years ago, was published in 2011, just looking at what people with bleeding disorders use to treat heavy menstrual bleeding. And at the top of the list at that time was oral contraceptives, and then we'll see desmopressin, antifibrinolytics, and then less commonly clotting factor products, and really rarely the intrauterine device, which I think if we redid this data, which we should have soon with some projects that I've been working on through the American Thrombosis and Hemostasis Network, I think the IUD is a more prevalent treatment. There's this publication from Andy James in Hemophilia, who notes that for women who have had evaluation and hormonal management is not helpful, or they desire pregnancy, they should be considered for hemostatic therapies such as desmopressin or antifibrinolytics and clotting factor concentrates. So we use tranexamic acid a lot. This is an antifibrinolytic, so it prevents clots from breaking down. And I think about the uterus is like highly fibrinolytic, like it's supposed to have that going on. And so if you can help prevent that breakdown, that'd be helpful. So we use tranexamic acid, or the brand name of Lystata. I think that this can be really helpful, but sometimes it's challenging for our teens who have less predictable bleeding, and so they don't know when to start it, or they don't know what days are the heaviest days. And the package insert says to continue for no more than 5 days, but if you're having your period or you're bleeding for 3 weeks, then is it reasonable to extend? And we do that. There's a little bit of controversy with regard to combining with estrogen, because there's this theoretical risk that if you're giving somebody something that prevents clot breakdown, it could increase their risk of having a blood clot, like a deep vein thrombosis or a pulmonary embolism. And then, as Dr. Baldwin said, there are a small portion of the population who have a higher risk of developing thrombosis while on estrogen, and that's usually due to some personal or family history of thrombosis. There's also, though, a lot of data of use of this medication, patients who are at high risk of thrombosis, that so patients who are post-op or have had heart surgery or trauma, and who do not develop blood clots. And so we generally feel like the risk of blood clots is more theoretical and not actual. And there are times where combining this with estrogen makes sense, and there's increasing at least case report or experiential data that this is a safe practice. There are some contraindications to this medications, like hematuria, or if somebody's really sick in the ICU with disseminated intravascular coagulation, and then rarely somebody with color blindness is not supposed to use tranexamic acid. Oh, sorry, I forgot I was doing the slides. Sorry, I forgot. I paused and was like, come on, Dr. Baldwin. Okay, sorry. And then, so the question about von Willebrand factor concentrate, if you have von Willebrand's disease and you're having heavy bleeding, should you use concentrate for this? And there's just not a ton of data out there, but there is an important study that Dr. Ragney is working on right now using von Willebrand factor for patients with heavy menstrual bleeding and von Willebrand's disease. That's randomizing, and it's a really important study that if you're interested and you have von Willebrand's disease, talk to your hematologist, because they are working on recruiting so they can get enough data to give us some true answers. But there have been 6 published studies, 2 prospective looking forward, 2 retrospective looking back, and 2 observational studies. In total, there's been 88 women in these studies with type 1, 2, or 3 von Willebrand's disease with heavy menstrual bleeding, who were treated with concentrate. And this was the majority received plasma-derived von Willebrand factor concentrate at varying doses and duration, and then a few who had received recombinant. And overall, patients reported improved bleeding with factor administration. This is just a summary of that data from the literature review of using von Willebrand factor concentrate in women with von Willebrand's disease. And it has the last one was this case report, or this other study, and this is additional studies. And so I think I've recently had this moment, which I think of, should we be using von Willebrand factor concentrate more? And I think I don't know. So there's some pros and cons. So the pro is that you're replacing what's missing, and that's how we've always thought about bleeding disorders, is you can replace what's missing, and that's what you're supposed to do, and rebalance this hemostasis, and it's effective. I think there's some cons of that we have some other therapies that are preventive, so that you don't have to get to the point where you're having heavy periods, and there's maybe targeted therapies with hormones. Factor, as we all know, is expensive, and it can be logistically challenging because of the route of administration of IV. And we have more information with some of our other therapies. But there was recently with the FWGBD, we were talking about what's the definition of a joint bleed, and we are quick to give factor for a joint bleed, and why is it different for heavy menstrual bleeding? I'm having a little crisis of thought of why are we approaching this any differently? And yes, it's expensive, but is that the problem? Or, is it logistically challenging? Then why aren't we teaching more people how to administer factor? So anyways, I'll continue to have my existential crisis about this, and we'll hopefully get some data from Dr. Ragney that can inform our thoughts. So this is one algorithm that has been proposed, but I think, as Dr. Baldwin said, we really have to sit and talk with the patient and discuss what their goals are. And so there's some thought to start with, what does the patient want to do with regard to fertility? And then if they don't, then there's maybe different options with regard to surgical interventions. But if they do, then is it a matter of this patient wants to become pregnant right now, and so avoiding hormones is important? Or if they don't, then maybe hormones is a good step. So just with that, hormonal therapy is of course, an effective first-line option, and tranexamic acid provides a good non-hormonal option, and it tends to be more effective than DDAVP. And then factor concentrates, I will revise and say, are an option for hormone non-responders or those who desire pregnancy, or maybe beyond if we get more data. But it's always important to have this discussion with our patients. So I wanted to talk though about iron deficiency. This is my little soapbox because I think that this has largely been under treated in a long line of history. So there is iron. I love this quote from one of the great pediatric hematologists, that iron lacks the glitter of gold and the sparkle of silver, but outshines both in biologic importance. So there's a ton of things that iron is important for in the body. We as hematologists think about this most often as hemoglobin, the protein that carries oxygen in your red blood cells, but there's tons of other proteins and enzymes that require iron to function. We think a lot about like our iron economy. So we generally as adults have 4 to 5 grams of body iron, but we only like lose or gain 1 or 2 milligrams of iron a day. And about a milligram or so is lost each day through our sloughing of our cells, like our skin and mucosal surfaces. But then another milligram of iron is lost daily in somebody who's having periods. So if you think, like I always think about our teens that are like, I've bled for the last 3 weeks. Why am I iron deficient? I'm like, well, because you're out of balance. You've lost all this iron. It makes sense that you haven't been able to keep up with your demands. If you're exercising a ton, you need iron to build your muscle. So that can be another demand. People who are pregnant, the fetus steals all the iron, so they need a ton of iron. And so it's just important to think about where your iron's going and where it's being lost. We absorb iron from our intestines. Typically, the iron that's in heme, which is in meat, poultry, and fish, is much better absorbed than the non-heme iron, which is in plant foods like vegetables, legumes, and nuts. And I always think it's fun to know that we don't actually know how this heme iron is absorbed. So it's always good mysteries in our bodies to learn and discover someday. So I just wanted to talk a little bit about the non-blood effects of iron deficiency as well. And this is really kind of old data at this point, but it was from a national survey from the late 80s to early 90s that included almost 5,400 children who were ages 6 to 16 years who had done some blood work and then did 2 standardized tests of cognitive function. And they looked at iron deficiency in these patients. And they found that the patients who had iron deficiency were more than twice as likely to score below average on math tests. And the difference was most striking in adolescent females. So this graph is on the x-axis, different categories of patients that they evaluated, and then on the y-axis are math scores, and then the grayed boxes are patients who have normal iron, and the white boxes are iron deficient. So the difference between math scores is quite significant, but most significant in the adolescent females. There's also tons of studies, and I won't go through all of them, about how patients with heavy menstrual bleeding and iron deficiency have impaired health-related quality of life, and that those improve when you correct the anemia and iron deficiency. And in addition, there's lots of data out there that in children with iron deficiency anemia, there's higher rates of depression, bipolar, anxiety, autism, developmental delay, and attention deficit disorder. So really like wide-ranging effects of iron deficiency. To treat iron deficiency, we have to do a few things. And I always feel bad for our patients when they come to clinic, we're like, you need more iron. And their parents are like, I told you needed to eat better. But diet alone is usually not enough to correct deficiency, but it's an important part of preventing iron deficiency in the next step once we correct the iron deficiency. So we first start with correcting the cause. So I didn't take this out, but for our younger patients, they drink a lot of milk and that can cause iron deficiency anemia. It's not the problem in our adolescents, but we stop bleeding is most importantly. And then we work on either oral or IV iron supplementation. I'm going to go back to that for a second. So oral iron supplementation sometimes can cause some side effects like constipation or stomach upset. And sometimes it's just, sometimes you just don't want to take it. And so I always talk to my patients. I'm like, this is really important. You need to get your iron up. It'll help you feel better. Can you take an iron pill once a day? And I was like, I just need you to tell me yes or no. And then if they say no, I was like, okay, we're going to sign you up for some IV iron. Other times where I'll go straight to IV iron is if somebody has ongoing blood losses that we're working on getting under control. And I just think it's going to take us a while and I need to offset those losses. Or if they have really severe iron deficiency anemia and we just need to like get them a bump so they can feel a little bit better. I think especially right now, our teenagers especially are feeling all the effects of the last couple of years of COVID and social isolation and total disruption of normal teenage development as a result. And so there's just a lot of feelings out there and being low on iron doesn't help. And so I've been quick to try to get people's iron better so we can at least cross it off the list of things that are contributing to the blahs that are this time. So in summary from our presentation today, heavy menstrual bleeding is common in women with bleeding disorders. It's important to identify somebody in the healthcare community that can work with patients to find the best treatment for symptoms, and iron deficiency is common and it definitely has to be treated. So I'm gonna stop our sharing there and we'll take time for questions.
Okay, I'd like to thank Dr. Haley and Dr. Baldwin for taking the time to join us this afternoon. We're going to go ahead and move into the Q&As. We've got one question right now. Let's see if we can get a couple more in. We have an anonymous attendee that says, I have recently heard that Heme-Libra may be a possibility for VWD treatment, off-label, of course. Is this something that you have an opinion on? Are there any studies on this?
Just so in case there's people in the audience who aren't as familiar with Heme-Libra, this is a medication that was approved for patients with hemophilia A that replaces the function of factor VIII. There's some reports of its use in von Willebrand's disease, more often patients with either type 3 von Willebrand's disease or severe type 1, or where the factor VIII level in patients is also really low. The advantage of Heme-Libra is that it's a subcutaneously administered medication, so it's a much more like logistically easy, quote unquote easy medication. I haven't really thought about it like as far as like its use in heavy menstrual bleeding. I think, yeah, I would say I don't know. I think that I would say we need more data for this as far as its role in von Willebrand's disease and then in heavy menstrual bleeding. Again, I think what I always get stuck on, and maybe it's not the right place to get stuck on, is that if somebody doesn't desire pregnancy and we have these really safe and effective hormonal therapies that can decrease bleeding that are really cost effective, and then versus a medication like Heme-Libra that's much more expensive, like, you know, if they're equivalent efficacy, then is it like, or, you know, like then maybe that's okay, it's good to go to the hormones. But I just think we don't have the data for that. And I don't know, I don't know when we would get the data.
Awesome, thank you. So how would you approach teen patients that don't take their condition seriously? Do you have any tips or tricks?
Just regarding don't take heavy bleeding seriously, I think we we do have some teens who have difficulty with hygiene, who are just busy doing their lives, and they can't really be bothered to keep track of how things really are, or to remember to take a medication every day. We try to find a way to connect with them about what's important to them, and pretty universally, having accidents, especially social accidents that they don't have resources for, like having hygiene products at school or having an extra pair of pants or something, are pretty motivating, and finding ways that we can help get them to their goal. And that might also mean that we're saying, oh, you really don't want to be on this medication. Let's make a plan for how to stop taking it and what's going to happen if you stop. Because there are a substantial number of teenagers who just have a few heavy episodes that lead them to iron deficiency anemia in the first year after menarche, but then their body figures it out. They get more ovulatory cycles, and it's not so bad after that. And so sometimes it's really just a short-term management, and I try to emphasize that it doesn't have to be forever. We're not signing you up for this lifelong therapy. We're just trying to get back in balance.
I totally agree. And I think sometimes it's like, okay, you're not ready today. Like, let's see you back in a couple months, and trying to decide, is that safe, or, like, I think, again, just really like talking through, like, why are you here today? What brought you here? Okay, let's talk about how we can prevent that thing from happening in the first place.
Yeah, I'm getting a question. Is hysterectomy an option for women who don't want any more children? It isn't the most cost-effective or safe management. And it's not that it's completely ruled out, but most insurance companies, knowing that, will recommend an attempt at medication management for approximately 6 months first. And so sometimes we're going through phases of trials. Now, a lot of people come to a gynecologist having already had a trial that was unsuccessful, and we sometimes discuss endometrial ablation as another option if they're a candidate for that, which is pretty effective as well. But it's not out of the question. We don't do hysterectomy under age 18, though. So it's not usually something we talk about much in our clinic. And then I wanted to just mention, like, when someone comes to a gynecologist, and they think they might have a problem with bleeding, but there isn't a clinic like ours set up to do this kind of assessment. How can they advocate for themselves? Because it's not always the first thing a gynecologist will think about to screen for bleeding disorder. And furthermore, many gynecologists, myself included, are a tiny bit afraid to interpret a von Willebrand panel of lab test results. And so they sometimes shy away and would prefer to just do the treatment. And so I would say that for patients coming to a gynecologist, they should really have a good handle on something similar to what a PBAC score would be, some kind of objective measure, an understanding of the things they've tried already. And then they can point to a couple, like the NHF website, or any of the other resources out there with tools for screening for a bleeding disorder. And I think that showing a gynecologist their score to one of those tools could be a really helpful way to start the conversation.
Yeah, that's a good point. And then, or even taking like the self-bat on the Let's Talk Period website or something, to be like, this is my bleeding score. And then there was also a question about IV iron dosing. So historically, there was some fear, or maybe not fear is the right word, but like historically, the iron preparations caused a lot of toxicities. Iron is reactive, so it has to be like chaperoned in the body, and so prior iron formulations were more toxic and could cause more side effects. The newer iron formulations are generally very safe. There's a small risk of anaphylaxis with IV iron, but that is a really low risk side effect, and is not typically seen. And more commonly, there's some rarely low blood pressure during the infusion, but mostly I always tell patients it's kind of just boring. There's a few different formulations that either can be given as one big dose or as a few smaller doses, and it depends what the hospital or clinic has available to them to depend which IV iron formulation you can get. And also sometimes insurance requires trying one versus another because there's different prices for the different irons. And then it's given usually in clinic over 30 to 60 minutes. If you get the one big dose and you're done, that often is enough to like fill your iron tank. And as long as you're not having ongoing losses, you usually don't necessarily need another dose. And it's kind of like a fix it and it's over, as long as you also are addressing the underlying cause. And then there was a question about heavy menstrual bleeding in Glanzmann's thrombocythemia or other platelet disorders. So I'll just speak a little bit and then turn it to Maureen. But I think Glanzmann's thrombocythemia, I think probably presents a more a bigger challenge than some of the other platelet disorders. I think our general approach is that like anything works, but in Glanzmann's, that I would say that our theory is to never turn on the faucet of like the blood flow. And so if you can prevent the faucet from turning on, that's better than trying to turn the faucet off. But I'll turn it over to Dr. Baldwin to talk more about that.
Yeah. Glanzmann's uniquely is the one bleeding disorder that is very challenging to manage. Pretty much all the other ones can be successfully managed with any of the tools in our toolbox that we've talked about today. But Glanzmann's is uniquely difficult, and many platelet disorders are a little more challenging than some of the factor-related disorders. But I think that there is not a lot of research about prophylactic or preventive treatment right at the time of menarche. And I think that's a question that's out there is, right before we think someone's about to start their first period, if we know that they have Glanzmann's, should we be doing something to prevent the first period even from starting? In my experience, a lot of times people will just add more hormone and more hormone and more hormone, and particularly will add more estrogen. And it's not always very successful to have more and more and more estrogen, creating an even thicker uterine lining. We have had success with the IUD in Glanzmann's patients, but typically it needs to be placed at a time when the uterine lining is already thin, so it doesn't get expulsed or come out with the flow of another period if the lining still is thick. So that is the one time when I have in the past given a recommendation that I strongly recommend, like it would be a cardiac bypass, that you have an IUD placed. And so that's a different conversation than what we mostly have in clinic, which is much more patient-centered.
Okay, I've got one more question for you. We have from an anonymous attendee. I have great presentation. Any plans for further publishing in the future? And where can we follow your research?
I'll start. Sorry, it's always like, who's going to talk? So hopefully, so as I said, I've been working on a project through the American Thrombosis and Hemostasis Network focused on women and girls with bleeding disorders, and trying to get some more information from that data set, and then refine the data that's being inputted so that we can make sure we're capturing information that's pertinent to women and girls with bleeding disorders. Very excitingly, we just got all of our data, so data analysis will be commencing momentarily, and hopefully we'll have some publications out in the next, I don't know, maybe spring, summer, I would say. Look for those in a hematology journal coming to you.
My work in this area most recently has been focusing on dosing of regimens as well as preferences that teenagers have. And you may find a study published hopefully soon where we surveyed teens on TikTok. And we got 5,000 responses immediately, pretty much, from teens just telling us what they would want their periods to be like if they could choose. And we had approximately 40% of participants who had heavy bleeding. In a large transgender population also. So we're putting that data out shortly, basically telling us that that teens prefer to have a little bit more predictability. Thanks so much for listening today.
Yeah, I'd like to thank you both one more time for taking the time to join us this afternoon. We appreciate your time and expertise. I'd also like to thank each of you for joining us. Please note that this recorded webinar will be available on Friday, December 3rd at hemophilia.org under the Events tab with all of our archived webinars. Also available in the Events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you again for joining us this afternoon and have a wonderful week.